There we go.
Thank you. I'm back.
Thank you.
So,
Sorry.
so basically, what happened is that since she was getting sick, during daytime, she was discharged home with mom, and at the night, she had to go back to the hospital to get peritoneal dialysis until they came to see us. And when I saw this case, I mean, obviously, we started with peritoneal dialysis. The child looked great. And I say, okay, let's try to see what happens if you do not dialyze this kid and to see what happened at this point. And what happened is that you look at the urine organic acid. When the child is sick, look at the ketone bodies extremely high, and look at the adipic, subaric, and sebacic. They're pretty much normal. And when they is sick, there is metabolic acidosis, the CO2 is 5. When it's well, you still see a lot of ketone. You still see no adipic, subaric, and sebacic, and the CO2 is 27. So what was happening here is that obviously the child, during fasting, release more fatty acid, utilize them, produce more ketones, and they become severely acidotic. But even when well, the child is severely acidotic. So how did we confirm the diagnosis? We sent for enzyme acid, and enzymatic acid activity was 0. Dr. FAO2 at the time sequenced the gene for us, and the child was homozygous for a stop codon. So obviously this child has a severe SCOT deficiency, and the way around it again is to give high dose alkali. With the alkali, what you do, you counteract the production of ketones, or you counteract the acidosis. Obviously, if you counteract the acidosis until the child does not get nauseated, can continue to eat, you start giving some cornstarch that produce calories without producing ketones. You increase the carb, you decrease the ketogenic food, and then the child starts doing much better and doesn't require the dialysis anymore. So this is pretty much the therapy of SCOT deficiency. What is the other condition that impair the utilization of ketone bodies? So this is the beta-ketothiolase deficiency. We call this beta-ketothiolase deficiency because methyl acetoacetyl-CoA transferase is harder to say. So, but what this enzyme does, again, once you generate acetoacetyl-CoA, you have two molecules of acetyl-CoA attached together. So you basically split them apart, generating two molecules of acetyl-CoA that can enter the Krebs cycle for energy utilization. So how do they present? Here we have many children with this condition. This is much more frequent than SCOT deficiency. And this was before the newborn screening. So this child presented with vomiting, lethargy, and did have hypoglycemia with 3+ ketone in urine, but also has severe metabolic acidosis with a bicarb of less than 5. And you can see here, increase an ion gap. And the glucose at this time was 95 because the child had already received IV glucose. So they did a HCT that was normal at this point, and the child was otherwise doing okay, but had a history of speech delay. And when we did enzyme assay, again, this is from some time ago, you can see that the enzyme assay actually was normal. But what happened for this enzyme, the activity of this enzyme is strongly stimulated by the addition of potassium. And that's when that was added, there was no stimulation. So basically what the enzyme assay told us, the enzyme is wrong, but don't ask me why. So to answer the question, we did a genetic testing that identified compound heterozygosity for a stop codon and a missense variant. So we started the child on fasting avoidance, cornstarch, and quarantine supplement, and started doing very well. So this is the typical presentation of beta-ketothiolase deficiency, where you have intermittent ketoacidotic attacks that are triggered by infection and fever. And there are two groups of patients who have no residual enzymatic activity. And I think that our patient was intermediate, he had some residual enzymatic activity, where the urine organic acid show characteristic metabolite, and the plasma content profile most of the time is abnormal. And then there are patients who have some residual activity who can have either intermittent biochemical abnormality, and sometimes you see really no biochemical abnormalities. These patients can still have episodes of metabolic acidosis and acute decompensation. So obviously the identification of these patients rely mostly on clinical identification, because the second group of patients can also have totally normal newborn screening. The diagnosis relies on DNA testing, and the therapy is fasting avoidance, cornstarch, and carnitine supplementation. What do you see in the urine organic acid? 2-methyl-3-hydroxybutyric acid, an excess of glycine. In some of them, you can see the 2-methyl acetoacetate, not shown here. But again, remember, the organic acid can be even completely normal sometimes when the patient is well compensated. In the plasma carnitine profile, when they are well, you see very mild to no increase of C5OH. When they are sick, you see an elevated C4OH, which is an indicator of ketosis, C5-1, and C5OH carnitine. So these are the marker of beta-ketothiolase deficiency. The urine organ, here there is a detailed listing of all of the abnormalities that you can find during an acute attack. But again, you have this abnormality in most cases associated with massive ketonuria. You have a lot of ketones as well, because the ketones here are made and not utilized. That is why you have the metabolic acidosis. And here again, why do you have the abnormal carnitine? Because this enzyme is involved in the catabolism of isoleucine. Remember, the 3-hydroxy-3-methylglutaryl-CoA liase was involved in the metabolism of leucine, not isoleucine. This one is leucine. So as a result, the beta-ketothiolase will result in the elevation of this organic acid that then get transformed into carnitine derivative. So here is again the differential diagnosis of an elevated C5OH in the newborn screening, and beta-ketothiolase is here. Now, we had patients with beta-ketothiolase who had different abnormality on the newborn screening. Some of them had elevated C5-1, some of them had elevated C5OH, some of them elevated C4OH, some of them elevated all three of them. Not necessarily they come together. And sometimes you repeat the test, you see an elevation of something else. So if you find different elevation of different diagnostic metabolite, think at the possibility of beta-ketothiolase deficiency. Because again, the metabolite that you produce might be dependent on how the baby is stressed and what the baby is eating. So in summary, today we have seen that fatty acid oxidation and ketogenic amino acids produce ketones in the liver that can be used by the body to produce energy. Disorder of ketogenesis, such as mitochondria 3-hydroxy-3-methylglutaryl-CoA synthase and liase deficiency, present as fatty acid oxidation disorder with hypoketotic hypoglycemia. Disorder of ketolysis that include MCT1, SCOT, and beta-ketothiolase deficiency, present with acute metabolic acidosis during fasting. Urine organic acid and plasma carnitine profile can identify abnormal metabolite in the 3-hydroxy-3-methylglutaryl-CoA liase deficiency and the beta-ketothiolase deficiency, but they can be totally normal in trimethyl trihydroxyglutaryl-CoA synthase deficiency and Scott deficiency, and also in deficiency of the transporter. All require DNA study for diagnosis. And I'm stopping here, and I want to acknowledge all of the people working in the clinic and in the laboratory that helped me in the diagnosis and management of this patient. I see in the chat that there are about 10 questions. I'm going to read them first, and then if I have a question, I'm going to ask the person who did the question to explain to me exactly what they mean, because obviously that doesn't help very much. The first question is Dr. Pete Baker. We use ketone salt up to 1.22 grams per kilogram per day. The content of the salt can limit this high dosing, so we have used formulation of different salt to keep any cation from getting too elevated. Again, 2 grams per kilogram per day correspond to about, they produce about 2 to 3 kilocalories per gram, and I do not know if, obviously, the sodium is computed inside the weight. So probably about 50% of that weight is due to ketone. So you would produce a minimal amount of calories by giving this ketone. There are formulations of ketones today that they do not have the salt attached to them. And obviously these are easier to use, and they don't have the complication of the salt. They are outrageously expensive. And obviously, being outrageously expensive, they might be hard to use in our patients. Kindly, Dr. Longo is referring to ketotic hypoglycemia type of GSD, which includes 3, 6, and 9. Ketosis is not prominent in GSD type 1A. This is only Dr. Areg Al-Garbawi could put this one, and she's absolutely correct, as usual. So, and those are the type of glycogen storage disorder I was referring to. The company we have used in the past was called Ketologic. They no longer provide custom salt mix to a flavor-free powder. So lately we use bulksupplement.com. We need everybody, please make a notice of this, because sometimes you might be wanting to use ketones to stop the cycle in some of the patients with both fatty acid oxidation disorder and multiple acyl-CoA dehydrogenase deficiency. I have to say that they've been used more in multiple acyl-CoA dehydrogenase deficiency than in all other fatty acid oxidation disorder.
So, Nicole, those were responses to a question that came up that you'll be getting to, and I'm curious to hear.
Yeah.
I do want to say that bulksupplements.com, they've got 3 formulations of beta hydroxybutyrate, calcium salt, sodium salts, and a magnesium salt. And we tend to have formulations to mix those together, and it's really inexpensive compared to some of the other non-salt based forms. But it still runs the risk of having hypernatremia, hypermagnesemia, and hypercalcemia. But I'll let you go ahead. You'll run into the question soon.
So Dr. McAndles is not familiar with these products, but a dimer of beta-hydroxybutyrate, does it get metabolized in that way? Yes, it's still metabolized by the same thing. So basically it gets picked up by the cell, and then it requires a few more cycles to get, but once it is attached to coenzyme A, and the Scott enzyme can still attach this one to the coenzyme A. The key is getting it attached to coenzyme A. Once it is attached, it can be broken down to everything.
That was actually, Nicola, the question was about, I wasn't familiar with the ketone esters product. And if I'm looking at the chemical structure properly, it looks like it's just 2 beta hydroxybutyrate molecules that are esterified to make a single molecule. And what I wasn't sure of is, how is that metabolized, and does it actually make it? Does it in the body? Does that get absorbed and broken down into 2 beta hydroxybutyrates and make an acyl-CoA ester? And I just wasn't sure.
No, it gets inside the cell and gets attached to coenzyme A. That is what it does. Once it is attached to CoA, then It is no problem. So
So,
you
so
still
that
utilize Scott and everything else.
So that would be that beta hydroxybutyrate ester form would be a great way of delivering the ketones without any salt.
Correct. The other way that people are thinking is attaching the ketone bodies or and something like this to glycerol, like you do with the trieptanoin, except attaching directly the ketone bodies. But people like to attach the shorter ketone bodies because you are sure that you will not utilize any of the enzyme for fatty acid oxidation.
Yeah, that I thought Johan had said that there was concern about whether the shorter side chains for the triglycerides are actually would be whether they would be released by the lipase and the intestinal lipases. There's something. There's like he said there was a chain link specificity. I'm not familiar with the data behind that statement, but that was the concern with the short chain triglycerides.
And he might be right. He might be right. So, and people have been trying, and the fact that they have not moved forward probably it is explained by this thing.
Yeah.
I didn't think about. Thank you.
Those of us who work with Johan find that he's usually right. So
would ketone supplement be beneficial for long-chain fatty acid oxidation disorder, especially CSCT? Probably they would. Again, what they do, they would suppress temporarily fatty acid oxidation, but then you would need to provide a lot of calorie in terms of carbohydrate to provide the energy. So again, their efficacy is used more to switch from a fatty acid oxidizing metabolism to a carbohydrate metabolism. And their answer is, we have a severe condition, and the answer is thank you. How does one differentiate between ketone generation from diabetes and ketone generation for MCT deficiency? Okay, so ketone generation from diabetes is the fact that in diabetes you tend to have hyperglycemia. The second thing, when you look at the urine organic acid, so first of all, you would differentiate a disorder of ketone synthesis from diabetes because the ketones are very low in disorder of ketogenesis. Disorder of ketone utilization, you have a high ketone like you have in diabetic ketoacidosis. Again, glucose tends to be low. We have seen, however, mild hyperglycemia sometime in beta-ketotiolase deficiency, but not 600. You need a glucose of 300, 400 for diabetic ketoacidosis, and here you get a level of 120, 130, 150, you don't get 350. The second thing, in the urine organic acid, you see a lot of fatty acid. So, fatty acid derivative, adipic, sudoric, and sebacic in diabetic ketoacidosis. You also see 3-hydroxy unsaturated fatty acid in the urine of patients with diabetic ketoacidosis. So basically, the urine organic acid would be very different in diabetic ketoacidosis from a disorder of ketolysis. So that it is how you differentiate that. But again, the presence or absence of excess glucose would be the key, in my opinion. And then the CME credit is this one. You need to fill out something, do it. So in Scott and beta-ketotiolase deficiency, what plasma beta-hydroxybutyrate level would make you suspicious? There is one. No. I mean, the reason is that I do more biochemical testing, but probably it would be a level of 2, 3, 4, 5, 6 micromolar of beta-hydroxybutyrate that would make me very suspicious. But it would be the elevation of the beta-hydroxybutyrate in the clinical context. So in other words, you would not interpret that by itself. You would interpret that one together with the full clinical picture. That would make me suspicious. Now I have answered all of the questions in the chat, and I'm still open. There are still a few minutes for questions if you want to pick up the microphone.
Nicola, hi, this is Arig. So I have just one question. Do patients with SCOT normalize, or do they continue to be ketotic, but in a lower range? I mean, I know you showed the difference between a decompensation and one that is in between, but when you treat them, do they go lower than what their baseline is?
They can go, so if you look at the urine organic acid, they can go in the 1,000, 2,000. But below that, no. So think a second to propionic acidemia. Propionic acidemia, most of the time in patients, even when they are not decompensated, you still have ketones. I mean, people ignore them, but they have ketones of 200, 300. Here, they are a little bit above the one that you see in propionic or propionic. In methylmalonic, I don't see many ketones most of the time.
Okay, and I'm sorry if I can do another question. So when you give ketones to patients with fatty acid oxidation, if you would give them increased carbohydrate, wouldn't that kind of dilute the effect of the ketones?
No, it provides the fuel for utilization. So in other words, you give the ketone, you tell the body to start utilizing the sugar. And then you give the actual fuel for them to use it. Now, we will have somebody at the Inform meeting in Jerusalem talking us how to use ketones in bikers when they do the Tour de France. I mean, and this is a guy who used the ketones in the Tour de France. So probably the guy who won was one of his guys. So, I mean, we have to listen what they do, but I think that what they do, they give the ketones just before they have a sprint, because in this way, they shift for a moment to utilizing the carbs, and they also give a sugary drink at the same time, but I do not know this yet. So we will, and I'm not sure he's going to tell us all the truth, only the truth, and everything that we need to know, simply because he wants to have an edge on the other team. But but he will tell us something on how you utilize them. But we need to learn on how they do in the Tour de France to treat our patient, because if we learn how to use the energy when you're pushed to the max, our patient with fatty acid oxidation disorder are pushed to the max, like patients in the Tour de France, and they have a much harder journey than people in the Tour de France.
Exactly. Okay, thank you. And my thinking was that when you have a patient with PDH and you're trying to provide them to be on the ketogenic and you try to limit the carbs. So in this case, if you're giving the carb with the ketones, that's where my question came from. But it would be interesting to see what the speaker has to say. Thank you.
You are correct. In PDH, you do this way. But remember, in PDH, what you do, you get the ketones out of burning fat, not from ketones themselves. Because when you give the ketones, you give a homeopathic amount of calories from the ketones, just enough to tell the body that, you trick the body into thinking that they are, they're burning too much fat.
And it's presumably an insulin effect in the ketogenic diet. If you give carbs, you're going to make insulin stop the fat breakdown. If you're given the ketones, they're just going to get metabolized regardless of how much insulin's around, presumably.
No, that it is absolutely correct. The ketones do not require insulin for being metabolized, do not require the lack of insulin. So it is the release of fat from the adipose tissue that happens when the insulin drops.
Nicola, what do you think about protein supplementation or increased protein content for fatty acid oxidation disorders?
I don't think it is a bad idea. I think it is a good idea. And we haven't tried it as much as we have in glycogen storage disorder, but I think we might try. I mean, I had a kid in which I tried everything, including this one. And when it is very bad, nothing works. But I think that we need to push anything which is not fat. Let me put it this way.
Dr. Longo, I have one last question. I guess it's thinking about gene therapies. Do you think there's a specific tissue that you would target for a gene therapy with fatty acid oxidation disorders?
Well, I mean, you need to target more than one tissue because, I would target both the liver, the kidney, and the skeletal muscle, and the heart. So the kidney, not very much, but, obviously, all of them would be candidate. I don't think we have much information. It would be nice to collect information, if any, if people have done a liver transplant in patients with severe fatty acid oxidation disorder. Because in that case, it would tell us whether at least having an organ that can provide energy independently from fasting would be useful to know if that can normalize the function of some of the other organs. So that would tell us if targeting the gene therapy to one organ rather than the other may work. In animal model, gene therapy, but again, this has been given systemically, seems to be effective in preventing a lot of the complication.
Excellent. Thank you.
Thank everybody for your attention. I'm happy to be on time. I hope to see you next week at the next lecture. It's not me, but it's still interesting.
Thank you, Nicola, very much. Round of applause for Dr. Longo. And next week we'll have Dr. Amu from Children's National, who will be talking about OTC deficiency and urea cycle disorders. So thank you very much, Dr. Longo, and thanks everybody for joining. Have a great, safe weekend. Bye.
Bye.